What are your thoughts on the different tools that you're seeing today, whether it's clinical AI or whether it's administrative AI? What are you seeing that's giving you cause for concern?
For me, most familiar on the clinical side, it will be these ambient AI scribes and a large language model that can use that conversation and generate a physician note. And it's been shown in studies to decrease the cognitive load of physicians. We have ChatGPT Health, and I know Claude have these patient-facing AI tools. So certainly there's some privacy concerns here, specifically with OpenAI. Do you trust OpenAI with all your health data? I do think that we need to embrace some of this disruption. I do think that the physicians who are familiar with AI are going to eventually replace the physicians who are not. It is
That's very
imperative
well said.
for physicians to at least be familiar with the trends in AI, because whether they like it or not, it's going to really disrupt how they practice medicine.
Welcome to Analyzing Healthcare podcast, brought to you by Scale Community. Scale Community is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events, to interactive peer networking opportunities, and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoyed today's discussion, please take a moment to sign up for your preferred membership level.
So welcome everyone to the latest edition of Analyzing Healthcare, the Scale Community podcast. I'm honored to introduce Dr. Kevin Pho to our podcast. Kevin, welcome.
Thank you so much. Great to be here.
It's a real treat to have you. And I get to ask you a question that I've been wanting to ask you for a very long time, because I've been aware of KevinMD for many years now, which is what possesses I think it was primary care physician back in 2004 to launch what becomes the number one physician social media platform in the country, if not the world, with 3 million plus monthly page views. How do you go from primary care physician taking care of patients in a practice, I think in New Hampshire, to media magnet? Walk me through that transition.
So I'd like to say that I had a business plan when I first started back in 2004, but I'd be lying. I had no idea where this would lead when I first started, because back in the early 2000s, as you know, blogs were just in its infancy, and there were only a handful of physicians who even had blogs. I think the aha moment for me was when I wrote something on my site, and the next day I was seeing a patient in the exam room, and she said that, "I read your blog post this morning and I was comforted by what you had to say, and now I realized that some of my questions were answered." So that's when I realized that physicians had a wonderful opportunity to not only connect with patients one-to-one in the exam room, but also one-to-many on these online platforms. And now, of course, it's not just blogs, but podcasts such as this. And it's grown into a site where not just I can speak, but a whole community of clinicians. And it's not just clinicians, by the way, it's just everyone across the healthcare spectrum can share their story, share an opinion, talk about what goes on behind the scenes in healthcare, and have other people read it, commiserate, and say, you know what, this also is happening to me. So the fact that it's resonated with so many people, to me, it's gratifying, and it's definitely been an evolution and has been organic since the very start back in 2004.
It's a sort of fulfilling the highest ideals of what we hoped social media would do, which is nice to see that these examples also exist. So there are over 1,000 professionals, I'm assuming that's mostly clinicians, that contribute articles into KevinMD.
So in terms of total authors, it's about 5,000 to 7,000. Some are one-off, some are regulars, but in terms of total amount of clinicians, it's about 5,000, 6,000, 7,000 since 2004.
Wow. So it really is a platform, a shared platform that a lot of people benefit from on the contribution end as well as on the consumption end, which is just fantastic. I don't know if you find this, but I'm still confused, shocked, amazed by what content generates what kind of reaction. I go out with analytics that I think are going to set the world on fire, meaning everyone's going to react and have their own opinion. And it's just, you can hear a pin drop. No one cares. And then I'll post a commentary on payer rates and growing inflation rates from different policies, premium policies across the country, commercial policies, and I'll get hundreds of thousands of impressions and all kinds of sharing and insight. And it's still a bit of an art form for me of what the audience, our audience, finds most interesting. Do you find that as well, or have you cracked the code at this point?
Well, if I cracked a code, then I wouldn't be here talking to you. I wouldn't be practicing. I'd be making billions of dollars, guaranteeing whatever I write would go viral. But I think what you're describing is really the puzzle that a lot of content creators have to solve, right? And that's the social media algorithms. And if we know exactly what would go viral and what would resonate with our audience and what would spread like wildfire, all of us would be millionaires.
Oh, I'm happy to hear you say it. Okay, so I'm not alone in this. All right, so jumping in, so the topics that are near and dear to your heart right now, what are the big issues that are occupying your mind, your heart, and what are the big issues that your audience seems to be most focused on that are current, that are contemporary? Walk us through top three.
So on my site, like I said, we have a lot of physicians who write articles and share stories behind the scenes of what it's like to practice medicine in the United States today. In terms of current themes, I would probably say burnout and moral injury is a prevailing one. Almost 50% of physicians exhibit symptoms of burnout, and we can certainly talk more about that a little bit later on as to why that is. But we have a lot of physicians write about some of the difficulties that they face practicing medicine. And the more difficult it is for physicians to practice medicine, the harder it is for them to give patients the care they deserve. Number two, of course, is AI. AI is affecting everything, and medicine certainly is no exception. And I know we're going to get into that later on. It's a little bit of a wild west right now because the technology is evolving at such a rapid pace, and the intersections that AI has with medicine and healthcare only grows by the day. So right now it's a little bit of a wild west. We have so many startups, so many tools that's coming out. They're throwing and seeing what's sticking on the wall, but we have to decide whether that's in the best interest of our physicians and, more importantly, our patients as well. And I would say the third most important topic is just a state of our healthcare system in the United States. Health policy definitely gets a lot of interest. It's no secret that we have a very, very expensive healthcare system in the United States, but our quality is not commensurate with the dollars that we spend in our healthcare system. And there's just so many facets and so many potential solutions that people bring to the table in trying to get and improve our healthcare system here in the United States. So I would say those are the top three topics.
Very meaty, all of them, and we'll jump into each of them. Let's start with burnout. So just on a practical level, if I'm a physician posting a recent example of what I'm being asked to do that's driving burnout on Ask Kevin, what can I expect in return? Am I going to hear from my peer group that I'm right? And are they going to sort of, I guess, sympathize, empathize, and drive more vitriol? Or am I going to hear a range of solutions? Hey, this is what I did to deal with that same problem. How does KevinMD help with burnout?
So it's a little bit of both. I think the issue that's facing physicians today is that we practice in silos. About 10, 20, 30 years ago, we used to have these physician lounges at hospitals where physicians would talk to one another and commiserate and share some of those difficulties more in a communal setting. Today, we all practice in silos. Physicians are very, very isolated. And when a physician faces difficulty, and it could be burnout, it could be depression, behavioral health issues, it could be topics like physician suicide, a lot of times they feel like they're the only ones going through it. So now if they share a story, if they're brave enough to write a story that's published on KevinMD, they're going to get a lot of feedback and a lot of comments and support from other physicians who read that article and say, you know what? I'm going through the same thing. And it's that really real feeling of community and support that physicians now don't have because we no longer have physician lounges, that I think is very affirming and sometimes can help bring physicians out of that feeling of burnout, that sense of community and the fact that they're not going through this alone. So that's the first part. And I agree with the second part that you mentioned. We have a lot of potential solutions. When it comes to burnout, I think the main driver of burnout is that there's an erosion of physician autonomy. And I think medicine has been very corporatized, and that a lot of the decision making has been taken out of the hands of physicians. And that's very disempowering. And I think that directly leads to burnout. So we have a lot of potential solutions. We have coaching. I know a lot of administrators like things like yoga and retreats. We have a lot of physicians who have non-clinical passions outside of medicine. And there's just a lot of ideas that are out there in terms of how to tackle this issue. I think the overriding fact is that more than 50%, as I said, of physicians are burnt out. And if more physicians leave the profession, what good is that going to be for our patients? Patients are just going to find it much harder to find a physician, find medical care. So I do think that this is a critical issue that needs to be addressed going forward.
Where did those rooms go where physicians used to hang out in person? Why are physicians more isolated today? And I guess let me build on that. You talk about the loss of autonomy. Let me package it all into one question. Is physician burnout getting worse? I know that you also mentioned changes in ownership structures, the loss of small practice, which is well documented and empirically very true, substituted by corporate practice of healthcare. So now it feels like the two leading employers or employment forms within healthcare for the average physician are either A, join a health system, hospital, typically health system, less hospital, or B, join a corporate MSO that owns and co-manages a plethora of practices. The option C, I'll start my own practice, is becoming less and less common. So when you look at those trends and maybe others that I've left out, where are we with physician burnout? If you were to track it as a graph, are we spiking? Are we plateauing? Are we coming down? What are your thoughts?
So I don't think it's a spike. I think that this has been a topic that's been on my site for at least 5 to 7 years. People always talk about burnout. If I were to give an answer, it would be a slow worsening trend. I think we're slowly getting worse. I think that the expectations of what medicine should be and the expectations of what physicians want medicine to be is not congruent with the reality of medicine today. You ask, where do all the physician lounges go? I think there are two reasons why those have gone away. Number one is that physicians have become more specialized. Back when I started internal medicine, I used to round in a hospital and then go see my patients in the hospital. Sorry, in my clinic. And now we have hospitalists, right? So I only see patients in my clinic and rarely do I see patients in the hospital. And I think that we're all becoming more niche. And that is one reason why we became more siloed. And the second, of course, is metrics, right? We have the corporatization of medicine and the focus on metrics. And we have a productivity based system where a lot of clinicians are compensated by productivity. So the more pressure they have to see patients and do more procedures, the less time they're going to have to socialize and commiserate with other physicians. So I think those are some of the drivers as to why that physician lounge has gone away.
Healthcare leaders, if your revenue cycle management is underwhelming you, it's time to rethink your current suite of solutions. Scale Healthcare's AI-powered RCM solutions are purpose-built to protect and accelerate revenue across the entire life cycle. Denial Shield proactively prevents denials before claims ever go out, using agentic AI to automate root cause detection and resolution. Front Desk Shield streamlines preclinical and front-end workflows, eligibility, authorization, and intake, reducing friction before revenue is even created. And Revenue Shield maximizes charge capture and revenue integrity, ensuring nothing slips through the cracks. Together, the Shield suite helps organizations reduce operating costs, capture missed revenue, accelerate cash flow, and increase productivity without ripping and replacing existing systems. If you're ready for immediate ROI and measurable impact, visit scalehealthcare.com and see how the Shield suite is redefining AI-powered us. It's hard to get it just right. I mean, offer you a few ingredients that are going to drive physician frustration and maybe even burnout that seem unavoidable. The corollary between A and B seems very strong to me. One is the loss of autonomy. You mentioned it. You might be a physician who joins a group that does everything better, but if you're no longer the decision maker, that's a significant switch from physicians that have grown up being individual practice founders and leaders. So the loss of leadership is very real. Another one is, as you mentioned, analytics. You might be a physician who's used to more of an artisanal approach to providing healthcare. Born of your residency, born of your training, born of your board certification, and that's it. And you're migrating into a paradigm that is meaningful use driven, that is EMR driven, that is analytical, that is benchmark driven. And that might all be good, except it does create a different paradigm and a different pressure and a different intensity. All those all those things seem like healthy transitions. Where the inflection point happens for me, in my mind, tell me if you agree or disagree, is when it's taken too far. When analysis leads to excess workload, too much efficiency gain, too little investment, right? Too much cost cutting, too much competition and benchmarking, you start to force physicians down a path which isn't good for them and isn't good for healthcare. So I draw a line, a distinction. I don't know that the normative goal is physicians are happy. If they're happy, all is well in the world, because physicians might have been happy in 1960 and 1970. And if we had very little oversight and a ton of annual inflation and maybe wide variance in healthcare performance, that wasn't enough, right? We need more than happy physicians. But I would say that physician feedback and physician good sentiment is critical. It's one of the critical pieces and should always be taken into consideration. Is that a fair description, or would you correct it and edit it in certain
Yeah,
ways?
I think that there's certainly a spectrum, right? So I think one of the issues is that there's a basic dissonance and tension between how physicians are trained and how administrators, what I call the MBA mindset, are trained. Because let's face it, administrators don't take the Hippocratic Oath, right? So I think that, again, you're going to have a incongruence if you have physicians who do everything for the patient and sometimes at the expense of cost and efficiency. That's going to run contrary to how MBAs and administrators are trained, who want to take a more analytical and a numbers-based approach to medicine. And I think that there's a fundamental incongruity there. So you're right. You don't want purely happy physicians, but you don't want purely metrics-based medicine as well. So the continuing battle is that where do we find that happy medium? Unfortunately, if you look at our healthcare system today, it's becoming more expensive and reimbursements are going down, and there's just more and more pressure on healthcare institutions and hospitals simply to stay open. So if you are against that backdrop and against that context, sometimes the numbers-based mentality is going to win out, and that's going to be at the expense of physicians and patients.
I couldn't agree with you more. I also think that it's such a rich topic because there's so many inputs. There's so many different trends that are driving this output of pressure and burnout. Another one that you touch on is reimbursements. I do think if outpatient care grows at 3, 5, or like hospital care, 10% per year, in terms of reimbursement rates over the last 10 years, as it has over the last 50 years, you would have less burnout. But instead, you have a wide divergence in reimbursement rates between outpatient care, primary care physician reimbursements, anything outpatient, frankly, from urology to dermatology to dentistry, you keep going. Every one of those groups, vascular groups, has seen significant price cuts that have resulted in an annualized average rate of inflation of between 0 and 1% over the last 15 years, which is actually deflationary relative to the rest of the country, which typically in that same period has increased prices at 1 to 3%. So if your cost of living is going up at 1 to 3% and your income's going up at 0.5%, that's going to create frustration. It's called, the phrase that I've heard from the physician groups that I stay in touch with, I'm doing the same amount of work to earn less, or I'm working harder to earn the same. And that in itself often feels like burnout. So it's just such a rich topic. I want to ask you from a regulatory standpoint, whether it's, we saw in the last administration with Chairman Khan at the FTC, at the we saw a focus on antitrust enforcement, and we also saw a focus on private equity ownership of healthcare assets. With this administration, we've seen a focus on drug negotiated prices, right? And we've seen a focus on transparency, and we've also seen a focus on fraud within federal funding. And we've seen it at a smaller scale, different initiatives coming out of the Medicare Innovation Lab, CMMI. So the expansion of ACO REACH into a new ACO program that goes beyond primary care. So all these different initiatives coming out from different administrations, which regulations are you following most closely and you hope will be enacted, and which regulations do you think will be counterproductive?
Yeah, so such a, like you said, a rich question, so many directions that we can go here. So let me focus specifically on private equity. I think that's something that I'm more familiar with, certainly talking with some of the guests on my site and the articles on KevinMD. I know private equity has infiltrated a lot of different specialties, and specifically,
you make it sound like a virus.
Yeah, has infected a lot of specialties.
There you go.
specifically
Don't hide how you really feel, Kevin.
emergency medicine and dermatology and gastroenterology. And again, speaking from the physician standpoint, I think that, again, those who run private equity companies don't take the Hippocratic Oath. So I think that the motivations are going to be a little bit different. So, like I said, I think that when it comes to money, business, a lot of the practice that they buy or a lot of hospitals they buy, they're floundering. They're looking for a lifeline, and private equity happens to be there. And the perception is that private equity will cut costs and then try to make that practice or hospital profitable and sell it at a higher price. And a lot of times that's going to be to the detriment of patients who are caught in the middle. I think that uh, when it comes to any type of regulation, I think that's probably something that needs to be looked at. I think here in Massachusetts, I live in New Hampshire, so I'm following what is going on with some of the private equity acquisitions here in Massachusetts. I think that there may be some potential regulatory pathways to help curb some of these abuses that private equity has in some cases, when it comes to the ultimate outcome and how it affects patients. But I do think that this is a trend that is going forward. And along with some of the other things that you mentioned, there's so many things wrong with our healthcare system, and it's very difficult in our political system to have a single broad stroke fix everything. So in the meantime, we're having a lot of these piecemeal solutions that kind of nibble at the edges without really changing the course of the proverbial Titanic towards the iceberg.
Yeah, my experience of regulation and private equity is that it's very much misunderstood. It's poorly analyzed, and so the resulting regulations are what you'd expect. They're misplaced, and they have at best a neutral effect, at worst a very negative effect. So when you take private equity participation in healthcare and you slice and dice it, you find that, like Paribo, 80% of it is actually very healthy and does a lot of good, comes with the right intentions, the right constraints on participation in clinical care versus administrative responsibilities. And the context to private equity in healthcare is actually, my experience, was mostly driven by fear and the loss of income, right? I think those same physicians growing their income, as we discussed, at a very healthy annual rate are less inclined to give up autonomy. But as soon as you drive up costs of care, of delivering care, by introducing all kinds of investment requirements, compliance requirements, reporting requirements, staffing requirements, and you don't balance that with investment in reimbursements, you get desperation. As you said, save my practice, as opposed to the greed component. I think the greed component certainly plays a role. And there are times where we saw in 2022, cost of capital is incredibly low and you see overpriced assets, over-levered acquisitions. And then you get some of the risks of private equity, which is what to do in a bubble, excess speculation. But that initial role that private equity played of providing investment, much needed investment and protection, the same catalysts that drive hospitals to come together, right? We're losing money, we need more scale. It's probably a healthy thing. And to see certain states ban private equity altogether, which is what we saw in Oregon last year, I think is an overreaction, my personal view.
The question then becomes, like, I think a lot of the points that you say certainly are valid from a financial standpoint. But I think that, again, speaking from the clinical standpoint, the question then becomes, do private equity owned practices, is it a net positive for patients? Right. So I think that when it comes to clinical outcomes, and I actually have to look this up because I didn't realize we were going to be specifically talking about private equity, but to my knowledge, I believe there are some studies showing that there is certainly not an improvement in patient care in private equity owned practices, and may be a little bit of a detriment. Going beyond the numbers, the question as a physician, I have to say, do any of these changes, will they improve the health of our patients? And I think that outcome is in question.
We should definitely book time to have that conversation. I'm going to take the other side of that argument. I think private equity increases patient care exponentially. It's not even close, but I want to go through that lengthy debate with you. It's a really fun debate because there are ways to argue very effectively that it doesn't. And I find those arguments to be brilliant as well. For example, what happens to patient care when a balance sheet blows up, right? When an asset declares bankruptcy, what happens to patient care? And the frequency of bankruptcy goes up the more that you introduce debt into the equation. And private equity definitely, as a rule, systemically introduces debt. So you will have these examples where patient care is definitely suspect. We've seen a large health system, I think in Massachusetts, that recently went through a liquidation. And what happens to nurse staffing? What happens to coordination of care? What happens to staff turnover rates when benefits are called into question? All the disruption associated with distress, insolvency. So there's definitely risk with private equity, but the counter argument is always very important too when you're having debate. What happens to these practices without private equity? And what happens to patient care and access to care without private equity? And so you always have to ask that question in healthcare. If not this group, then what group? Mm-hmm. And the idea that there's always a backstop, the government or the state, local government will always be there to provide access is false. We've seen that here in the US, where access is not always guaranteed, and we see wide variance in healthcare outcomes born of access. And by the way, nobody likes that. Everybody wants investment in healthcare, and we see it overseas as well. So it will make for a very fascinating debate, and I definitely want to invite you to do that with me. So, but I'm not going to drop it on you now because it's not fair. So we're gonna move on into this next big topic that you mentioned, which is AI. I think AI in healthcare is going to be another source of a keen interest to your entire audience, your huge audience, because it already is showing signs of being highly disruptive, highly speculative, and in many cases might result in adverse outcomes for physicians and for patients as well. So I share your fear there. I'm actually probably more fearful of AI in healthcare than I am private equity in healthcare, which I think has the potential to do less damage than AI. So what are your thoughts on the different tools that you're seeing today, whether it's clinical AI or whether it's administrative AI? What are you seeing that's giving you cause for concern?
So I'm going to speak from the perspective of clinical AI because that's what I'm most familiar with. So just to kind of give context and to add on what you're saying, I do think that AI is going to be tremendously disruptive to our healthcare system, just like every other. But I do think it's going to be tremendously disruptive when it comes to our healthcare system, just like with every other industry. And the question is it going to be a net positive or a net negative for our patients? And that outcome is a little bit in question, right? So I think it's very early. ChatGPT just came out 4 years ago, right? And we're very early in this. And now we have just so many tools that are available out there that impact both doctors and patients. For me, most familiar on the clinical side, it will be these ambient AI scribes where a phone will be listening to the conversation, and then there will be a large language model that can use that conversation and generate a physician note. And it's been shown in studies to decrease the cognitive load of physicians. It slightly improves the time spent in the chart. But I think I talk to a lot of physicians anecdotally, and they talk on my podcast and cite about some of the stories about how that decreased cognitive load is improving their health, improving their burnout, and just improving their lives in general. I know that recently we have ChatGPT Health, and I know Claude have these patient-facing AI tools where patients can upload their entire chart into a large language model and then ask it questions basically about some of their conditions, diseases, treatments, and questions that they ask their physician as well. So certainly there's some privacy concerns here, specifically with OpenAI. Do you trust OpenAI with all your health data? What are they going to do with it? Very early in that, the ChatGPT Health just came out just literally a few weeks ago. So again, very, very early. From a physician standpoint, I do think that we need to embrace some of this disruption. I get asked a lot, is AI going to replace physicians? And I don't think it is, but I do think that the physicians who are familiar with AI are going to eventually replace the physicians who are not. So I do think it is imperative for physicians to at least be familiar with the trends in AI, because whether they like it or not, it's going to really disrupt how they practice medicine.
Yeah, I couldn't agree with you more. And I also think that we're entering a phase of such disruption, such potential disruption, that the time for a unified voice from physicians has never been greater. So I think the role that you play, actually, if it was really important before, it becomes critically important over the next 5 to 10 years. I do think, judging by past experience and events, our society, at least I can speak for here in the US, we tend to experiment a lot more and faster maybe than the average society. I maybe call us a little bit more liberal than some of our Western peer group. And so that's going to lend itself to sort of the cowboy Wild West approach to AI. I know there's going to be different states that move faster and slower, but there are physicians in every state. And the idea that AI at some point will transition from co-pilot to autonomous and will actually dictate clinical care is, I think, a real I want to say risk, real possibility. And I think that no matter how you look at that, that is a source of friction, right? Because that is a very different paradigm than the one that you and I have grown up in. And very scary, actually, to think about. And so if I had to forecast for AI in healthcare over the next 10 years, assuming we're all still here in the next 10 years and it hasn't wiped us out, I would say we'll probably find that there is a bunch of AI tools that physicians love, just for the reasons that you stated. They create time, they create freedom, they remove concern, risk, and complexity. They answer questions, they enlighten, they provide information. Patients are more informed. It's great. And so I think you're going to find these tools that are a source of more physician happiness. They address issues like burnout. But then I think they're going to be all these tools that different companies, different states, knowingly and probably more likely unknowingly experiment with, that take time to reveal themselves, what they actually do, right? And those horrific case studies will have to surface, and we'll have to sort of wave a flag and say, wait a second, that's going too far. That doesn't work. That has all kinds of adverse events, adverse outcomes. It's making life worse. And so it's scary because you want to avoid that from happening in the first place. And we'll all do our very best to avoid it. But to some extent, we only know so much, right? So do you have a similar sort of forecast, a prediction for what AI will do to healthcare? Does that sound about right? The good and the bad.
Yeah, I think that again, we're so early. You mentioned what's going to happen in the next 10 years. I think 10 years is way too long. What's going to happen in the next year? I think if we had this conversation in 2027, it could be much different than the conversation that we're having now. I think the potential of AI to cause disruption is so great, and there's a propensity in Silicon Valley to move so fast, right? The mantra is move fast and break things. That's literally what they do. And I think in healthcare, that can be very dangerous, because if you break things in healthcare, people die, right? So I think that you want to liken, and I had a guest on my podcast talk about this, you want to treat these new AI tools almost like a medical device. And before a medical device goes into the consumer's hands, or before a drug is prescribed, what happens? You have to go through all these trials, right? Phase 1, 2, 3 trials to make sure that they don't do any harm and make sure it improves the health of patients. But it's very unlikely, if not impossible, these AI startups is going to go through that same vetting process with whatever tools that they're going to come up with. They're just going to be first to market and have marketing slogans about how it's going to improve the health of patients without the proper clinical trials that say so. And I think, again, there's a little bit of a tension there between how healthcare works and how the philosophy of a lot of these healthcare AI startups work, where they just want to be first to market. So I think that we need to be very careful, just because the tools that we're playing with specifically with AI are so powerful, and it can fundamentally change the lives of our patients for good and for not.
That's a great point, right? The average timeline from trial to commercialization of a drug is 10 years. Can you imagine if a venture capital group had to wait 10 years on an AI startup, new technology, before it could potentially commercialize $1, spend several $billion in the process on demonstratable trials? And I still think, taking that extreme example, the core point that you're making has tremendous value to it, right? What is the safety net? What is the preventative program that we've built in place to evaluate the potential harmful effects? I know startups focus on the upside, but in healthcare, as you said, the Hippocratic oath, patient safety first, right? What mechanisms do we have in place to protect that downside? And I'm not sure that I've seen too many yet. So it's always a scary time when technology moves faster than our regulatory bodies can keep up with them. It's also scary when our regulatory bodies catch up, and because they don't always do the best job imaginable, right? Some of the adverse events that we've seen in healthcare have come from bad regulation. So risk is everywhere, but needless to say, it is a scary time for AI in healthcare. I do think some of the challenges that we face in healthcare push us along this path at an accelerated pace. So actually, these issues like physician burnout create their own worst enemy, because they force us into a sense of panic, right? And we look for whatever is out there, whether we touched on private equity or whether it's AI creating clinical supply, and we grab onto them because we're in a state of tension. So that is a genuine concern. Are you focused on some of these other supply related issues that maybe aren't AI dependent? I'll give you a good topic that I've looked at. and find fascinating, which is the cap on annual residency programs. I don't know whether, I still haven't worked out whether it's 40,000 or 80,000 total annual residencies per year, but it is relatively capped. It is predominantly reliant on Medicare funding. It is an incredibly antiquated 40-plus-year-old system that we're still following today. And it has no correlation with the US population, which has gone from 200 million to 350 million in the past 50 years. None at all. So when we talk about burnout, one wonderful way to create less burnout is more physicians. We don't do that. We have very few physicians that go through 5 to 10-year training programs, if you include medical school, let alone if you include fellowship, and very little funding that goes into creating more physicians. And we also have a restriction on overseas physicians participating in our US growing population. We don't allow it in any way. They have to move here to participate. So any thoughts on, forget AI, other elements that drive physician burnout?
So I think what you're saying is right. There are bottlenecks and constraints when it comes to physician training, specifically the residency cap. I don't exactly know the exact number, but I think that whenever it comes to money, right, there's going to be resistance to spending more money and creating more residency positions. So I certainly think that is one bottleneck. I'm going to speak as from the perspective of a primary care physician because that's what I do. And even if there were unlimited physician positions specific to primary care, I'm not sure a lot of medical students are going to choose primary care because of the practice itself is going to be incongruent with how a lot of medical students envision themselves practicing. And the same goes for rural medicine as well. So just because you raise, say, the residency cap, let's say you double it, that doesn't mean that there aren't going to be physician shortages in specialties that need physicians the most, like primary care, or places in the states that need primary care the most, like rural areas. You're just going to get more physicians concentrated into more desirable practice areas, right? So it's going to take more than just training more physicians. I think that there are going to be some structural changes that we need as well to encourage more students to become primary care doctors or to practice in underserved areas.
I think it's a great point. My only counter to that is, when's the last time we had too many physicians in any specialty? I hear the physician shortage argument across the board. So it'd be nice to at least know that half the specialties have more physicians than they need. That would be an interesting environment in which to participate. I've never seen it. All I've seen is physician shortage for the last 15 years that I've been in healthcare. So Kevin, I want to thank you for your time today. I know we covered a lot of very different topics, but all focused on trying to make healthcare better, starting with the US and maybe elsewhere as well. So really appreciate your time.
Thank you so much for having me on. It was great.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.